Hi, I'm Dr. Lenora Coleman, President and founder of Healing Our Village. Thank you so much for tuning in to our Advanced Diabetes program. We're real excited to bring these modules to you that will really improve your practice, both in the clinic, in the community, and in your pharmacy. Today's topic is called Bridging the Gap in the Diagnosis and Management of Diabetes in the Underserved and minority populations. And we're going to try to go through this with a lot of room for questions and answers at the end. So let's talk about the diabetes epidemic worldwide. This is a problem. Right now we have a tsunami. And if we don't do something about trying to stem the tide of diabetes, it is just going to be amazing. In North America and in the Caribbean, there's about 50 million adults, that's ages 18 to 99, that have diabetes. That's 1 in 8 adults. The prevalence of diabetes is 13%, and we know that 1 in 3 of people out there in North America and in the Caribbean are undiagnosed. So that's a third of the people do not even know that they have diabetes. It's responsible for about 378,000 deaths in 2017. And when you're thinking about live births, 1 in 7 live births are affected by hyperglycemia in pregnancy. We're spending a lot of money on the management of diabetes. We should be spending more money on the prevention of diabetes. And so we know that $440 billion, not million, but $1 billion was spent on health care for people with diabetes in North America and the Caribbean in 2017. Now here you see some global projections for the diabetes epidemic, and this is from the years 2011 to 2039, and this is in millions. And you can see that under every single block of the world, the number is going to go up. We know worldwide there's going to be a 51% increase in diabetes in the world. We know in Africa it's going to be 90% increase. And in the Caribbean, it's going to be about 36%. So we have got to stop this progression. And the thing that's so sad to me is it's not that hard. All we have to do is get people to decrease the number of carbohydrates in their diet and to try to get more exercise. And if they have diabetes, we just got to get them to see their doctors, monitor their blood sugars, and take their medications as prescribed. Now, when you're thinking about the natural history of diabetes, it's important that we do early diagnosis and treatment. And early diagnosis has to be done through screening. So we're going to talk a little bit later about the importance of screening for prediabetes. But this is a very interesting slide. This is actually from the UKPDS, looking at the amount of beta cell loss over time. And you can see that those patients who are in IGT or in postprandial hyperglycemia, which is known as prediabetes, those patients already are starting to lose beta cells. And by the time they actually get diagnosed at point 0 there, with diabetes, with type 2 diabetes, they've already lost 50% of their beta cell mass. So this is huge. So you want to understand why they come to your offices newly diagnosed with eye disease and kidney disease and heart disease. It's because they probably had hyperglycemia for about 12 years prior to that diagnosis being done. And so as you can see, as you continue in phase 2 and phase 3 of type 2 diabetes, there continues to be beta cell loss. So what we're trying to do with early diagnosis and aggressive treatment is trying to stem the tide of the beta cell loss. And some of the newer agents that are out there have actually been shown to help with that. Now let's talk a little bit about prediabetes. We know that it is an epidemic. And it actually has to do with the success of our society. So we are living longer. We are definitely eating too much. And as you can see, the gentleman who's got his dog on the treadmill, we are not getting enough exercise. Okay, so we have got to do something about all of this lack of exercise and obesity that we have in this country. We are the most obese country in the world. And there's lots of reasons for that we'll talk about in some of our other programs. This slide really gives you sort of the layout of why there's so much obesity in this country. And unfortunately, we're taking all of this pizza and hamburgers and fast foods to the other countries of the world because we want them to be as fat as we are. All right? So this is actually a corner in any city of the world where you can actually see prediabetes actually starting. You see the gentleman in the purple shirt? The question is does he have prediabetes? And that road that he's walking down is leading him to potential diabetes. So we have to stop this. Now, there's a myth out there. So it's a myth that a lot of people need to know that is not true. Okay? There's a lot of people who think that all I have to do is lose 20 pounds, all I have to do is get to 7% weight loss in my total weight, and I'll be able to decrease my blood sugar. Well, this was a study that I thought was very interesting. It was published in the Archives of Internal Medicine, and what it basically showed, what a 20-pound weight loss in this 135 patients, there were only 41% where their blood glucose levels actually responded, where the blood glucose levels actually went down. The other 59% lost the 20 pounds, but there was no change in their blood sugar. So can you imagine how disappointed that patient was when you told them that all they got to do is lose 20 pounds? And then they lost the 20 pounds, and now they're looking at you across the desk saying, "Hey, doc, what happened?" All right, so you have to understand that pure weight loss, sometimes in some people, is not enough. So when we're thinking about prediabetes, there's sort of these three things, A, B, and C, that you have to think about. We know that there are 86 million people here in the United States that actually have prediabetes. So if we don't do anything, we know that prediabetes, a third of people then go to diabetes, and we know that many of those people continue to go on to the complications of diabetes. So in number B, what we're looking at is we're trying to do something. We are trying to do some diet, some exercise. We're trying to start them on effective medications so they don't continue to have that curve that we see there. And we know that if we start early and aggressively, there's something called the legacy effect, which we'll talk about in a few minutes. And then we also know that in C, if you're very aggressive and you use combination therapies and some of the newer agents that are out there, we can really be able to decrease the complications of those patients with diabetes. Now, this comes from data. There were actually 3 major studies that looked at the management of prediabetes and looking at changes in lifestyle to be able to change their relative risk of going on to diabetes. The one that was done here in the United States is called the Diabetes Prevention Program. It had about 3,234 patients, and their baseline BMI was 34. This was only a 2.8 year study. In fact, it was so impressive that they actually stopped the study. They were going to go for longer, but they didn't have to. They showed a 58% relative risk reduction, and they only needed to treat 21 people to be able to see that risk reduction. Now, in Finland, they did the diabetes prevention study. That was 523 patients. Their BMI was 31. It was a 4-year study, and they showed a 39% relative risk reduction. And in the Dacheng study, that was in China, again, you can see those BMIs were very low, 25, because we know that our Asian population is not as obese as the non-Asian population. This was a 6-year study, and what they found, again, was a 51% decrease in the relative risk of going on to get diabetes. So this slide shows again the DPP study results, a 58% risk reduction from doing an intervention, and that intervention included a low-calorie, low-fat diet, and greater than 150 minutes a week of moderate intensity exercise. With metformin in that study, there was a 31% risk reduction, and even the placebo group got an 11% risk reduction. So that actually tells you something. Even if you don't do the drug therapy, just you educating and talking to patients can make a difference in their diabetes control. This was the data again from the Dacheng study where they did a follow-up. So they did the study ended at 6 years, and then they continued to look at that subgroup of patients for another 20 years. And what they found is over that 20-year period of time, there was a 47% reduction in severe retinopathy. So we know that if we can just intervene on those folks and keep this diet and exercise and their medications on the right trajectory, we can really significantly decrease the short-term and long-term complications of diabetes. Now, this is an algorithm that comes from the ACE. endocrinology group. And basically it's just the prediabetes algorithm where you start off with your lifestyle modifications. But if that patient already has high blood pressure, if they already have hypercholesterolemia, then as part of this prediabetes algorithm, you also have to intervene on those potential risk factors. And even if their blood sugars are starting to trend up to diabetes, then you may need to think about drugs like metformin or acarbose, which were both used in the diabetes prevention program. Now, this is a diabetes risk test. You can just go up online right now, just put in diabetes risk test, and you can Google it and get this. You can download it into your computer. It is a form that I actually use for all of my patients that I screen. We do a lot of screenings with Total Lifestyle Change and Healing Our Village, my two companies. And so before I stick someone's finger, they have to take this diabetes risk test because I need to see if they're at risk of diabetes. And so they have to score 5 or higher on this test, and if they do, then I do a random or an episodic blood sugar on those patients. So it's important that you do that in your pharmacies, in your clinics, so that patients will know if they have prediabetes. Now let's talk a little bit more about this legacy effect. It's really an interesting thing. So here was a study that was done in type 1 diabetes patients. You all are familiar with it. It was called the DCCT trial. This was the first trial that we showed that intensive management of type 1 diabetes can impact on retinopathy, on neuropathy, and on nephropathy. So we know that the microvascular complications of diabetes are greatly affected by trying to get your blood sugar as tight to normal as possible. Now, they actually continued this study. It was called the EDIC trial. And so they continued it. You see the 10-year mark, and then you see they continued it for 17 years. And what was interesting is that the glucose was similar between the conventional treatment group and the intensive treatment group. But the cardiovascular events were significantly higher. So there was a 58% risk reduction in those patients that had had intensive therapy versus those patients that had gotten conventional therapy. So this is called this legacy effect. There's a beneficial effect of tight and aggressive blood glucose control. Again, this is a UKPDS long-term follow-up, again showing the legacy effect. So you can see from this curve that the conventional and the intensive therapy group get to about the same A1C. But the most important thing is when you look at myocardial infarction, in that first part of the 10 years of the UKPDS, we did not see a statistically significant reduction in myocardial infarction. But as it was continued, that legacy effect kicked in, and you were able to see a statistically significant reduction in myocardial infarction in those type 2 patients that were getting intensive therapy. One of the other studies that I think is very important that we need to talk about is this idea of the legacy gap between clinical trials and real-world data. So you know that, or may not know, that Healing Our Village has done a lot of work around clinical trials and minority recruitment for clinical trials. And what we have found is that those patients that are in the clinical trials don't usually look like those patients that I take care of in my clinics around the country. So this idea of the real-world efficacy of drugs is what is shown in these two studies. So this is one that looked at GLP-1s, and we looked at the real-world effect of those drugs being used in clinical studies. And what we saw was in the clinical studies, they had about a 1.4% reduction in A1C. But in the real world, it's much, much smaller than that. And so the gap that you see can be explained by non-adherence to the medication. That explains 75% of this real-world gap. And then the other 25% is explained because of baseline characteristics of the patient. Even with the DPP-4 inhibitors, which you see in panel B. Again, the real-world results are in the clinical studies were 0.59%. For the clinical studies, but in the real world, it's only 0.52%. So again, that gap is explained by medication non-adherence and about the kinds of characteristics that those patients have to get into a clinical trial. So if you look at a lot of the clinical trials that have been published, all of the major sort of late-breaking studies that have shown us the importance of these various medications that we use every day, Advance, Proactive, Record, VADT, and even the most recent IMPA-REG trial, we can see that by and large, most of your patients would not have been able to qualify to be in those trials. And so, and we know this because in this particular study that was published, they looked at the total Scottish studies that were represented 180,000 patients, and they looked at the Royal College General Practitioner study, which represented about 60,000 patients, and then compared their patients to these various studies. So again, we look at the data. I think clinical studies are really important, but the one thing that we do here at Healing Our Village is we know that one size does not fit all. And so we are doing a lot of work in terms of just making sure that we're picking right drug for the right patient at the right time. I want to talk about clinical inertia. As pharmacists, this is the one thing that you can make a huge impact on. We need to help our doctors be more aggressive and change medications earlier in the course of treatment of their patients. So clinical inertia is defined as patients do not begin or intensify their treatment despite the fact that they're not achieving their A1C goals. So we know that this represents about 30 to 50% of the patients that you see that experience suboptimal therapy for a number of years. And the problem with that is during those years where their blood sugars are high, they're getting continued eye disease, continued kidney disease, continued heart disease. And so we have got to make sure that we focus on this clinical inertia. And as pharmacists, you can make a big dent in that. We know that inadequate glycemic control is responsible for over 200,000 diabetes-related complications per year in North America and results in a lot of increase in healthcare costs and tens of thousands of premature deaths. So this is a little slide that sort of goes through the sequential treatment approach that most doctors are using out there. So you start off with your first oral hypoglycemic agent, and then it takes you about 2.9 years before you add on the second hypoglycemic agent, and then another 6.9 to 7.2 years before you add on the third one, and then you and I have to have a conversation about, do you add on the third drug? All right, sometimes it's better for you to start thinking about plan B. Maybe it's time for insulin. Maybe it's time for an injectable GLP-1. So this adding the third drug sometimes just increases your cost and doesn't really do a big difference in terms of the goal you're trying to achieve in terms of blood sugar. And then another 7.1 years before we even start thinking about adding insulin to the patient. And then another 3.7 years before we're starting to either add a GLP-1 or we're starting to do split mixed dosing of insulin. So we cannot wait this long to be able to get that patient to their target numbers. We know that this is the way it generally looks in most offices. So you start with diet and exercise, then you do monotherapy, then you increase the dose, then you do the combination, then you add insulin, and then you start talking about multiple daily injections. What we want to do is knock down that blood sugar very quickly down to 6.5 to 7. And then we want to keep it there by increasing the doses and adding on medications as quickly as possible. At Healing Our Village, we're able to touch those patients about 3 times, and in a 9-month period of time, we're able to have a 1.6% reduction in their A1C and get a substantial number of our patients to their goal blood sugars. So this is why it is so important for us to become aggressive. But it's not all us. It's not all on the doctor. Patients start taking responsibility for their problems. They have to learn what I call health survival skills. They have to keep their appointments. They have to take their medications as prescribed. They have to get their daily exercise. They have to diet. They have to monitor their blood glucose. One of the things that we have at Healing Our Village are Bluetooth blood glucose monitors, where the patient is actually able to see their blood glucose on their cell phone. So they're able to see what their number is, they get to see their logbook, and they also get to see their trend lines. So they can see if they're doing a good job or if they're not doing a good job. So it's really important that patients know their numbers. But not only their blood sugar number, they need to know their blood pressure number. They need to know what their cholesterol is. And if they've had a heart attack, they need to be on aspirin therapy every day. They need to be taking their lipid lowering therapies as prescribed. So the patient has to participate in this process, or we're not going to be able to get them to the goal that we want them to be able to do. So it's important that you do something. I don't care what you do, but you got to do something, and you should not give in to clinical inertia. Now, there are some clinical guidelines for the management of diabetes and its complications, and now we're up to the egregious 11. These are 11 different parts of the body, different organ systems that contribute to hyperglycemia. So you remember the first one we had, I've been doing this for almost 40 years, and back in the day when I got out of pharmacy school, all we thought about was the pancreas and the pancreatic beta cell. And all we cared about was giving people insulin or helping their body produce more insulin. All right, well, we've come a long way from that. And as you can see, we're up to 11 different parts of the body that contribute to hyperglycemia. And the interesting thing is for every single one of these organ systems, there are medications that actually work in those organ systems to make your body decrease its blood sugar. So when I talk about right drug, right patient, right time, it's important that you have the right combination of medications so that that patient is, you're basically focused on what's going on with their specific organ system dysfunction. So here we have the drugs actually added on to the chart. And so you see for your pancreas, for your pancreatic beta cells, you're, of course, still using your sulfonylureas, but your incretins now are something that you're able to use. If you're dealing with your gut, you're talking about the incretin effect, then you have your incretins that are effective there. If you're talking about the alpha cell, then you're looking at increasing your glucagon, that's pramlintide, or your incretins for that. When you're looking at on the left-hand side of the chart, if you're looking at the colon, or if you're looking at the immune system, or you're looking again at the intestines, you have the probiotics for your colon, the incretins, you have metformin, you have the incretins for your immune system. So you can see if you're talking about the kidneys at the bottom of the slide, you have your new SGLT2 inhibitors that are available. And there are a lot of very new studies which have shown that these SGLT2 inhibitors are very effective in not only decreasing your blood sugar, but also has a beneficial effect on the kidney. We know that some of your incretin agents also have beneficial sort of side effects other than just decreasing blood sugar. So it's important that, again, you figure out what the pathophysiology of your patient is and then pick the right drug for those patients. Now, this is somewhat of a complicated slide. Again, this is available from the American Diabetes Association. All of you need to go immediately and download this algorithm onto your cell phone. You need to have this at your fingertips because this is how we treat diabetes in 2019. So this is the newest of all the algorithms that are out there. And you can, if you've been doing diabetes for a while, what you're going to find is this algorithm has changed. The way we think about the management of diabetes has changed. And so now, before we pick a drug to use, we have to figure out, does this person have cardiovascular risk? Does this person have heart failure? Does this person have kidney disease? And so based upon the answers to those questions, this algorithm tells you which drugs to start with. Now, we're going to have a program that just focuses on this algorithm and all the nuances of the algorithm, but I do want to bring your attention to two important points. If your A1C is greater than 9% or greater, you need to put them on insulin. And you need to get those blood sugars down. Oral agents are not where we want to do according to this algorithm. The second thing I want to bring to your attention is that sulfonylureas, they're at the bottom of the list in terms of the agents that you're supposed to start off with. Now, I know in 2019, there's still a lot of people who are on sulfonylureas. They get metformin first, and then they usually get an add-on of a sulfonylurea. And you can see that that is actually contrary to these guidelines. Now, you see that over there on that very right-hand side, on the very end, it talks about cost being a major factor. Well, that's when you're supposed to be using the sulfonylureas. But I submit to you that if a patient is given the opportunity to pick their medication, and you tell them all of the downsides of using sulfonylureas, which, by the way, is hypoglycemia is the major problem, they will probably elect to use some of the more costly drugs. And those drugs now are coming down in price every day. There are all sorts of prescription drug cards out there that decrease the cost of medication. So again, give your patient the choice. Don't just assume they are poor and therefore they have to be on a sulfonylurea. The other thing in terms of early combination therapy is that it helps you achieve your goals earlier. And there's a potential risk for side effects if you combine drugs at lower doses instead of increasing drugs up to their highest dose. And there's an opportunity to actually use maybe combination products. I know a lot of you have formulary considerations that you have to deal with. A lot of the combination drugs are not on formularies. But you know, we need to do some prior authorizations for some of these patients who are really having a hard time taking multiple medications. So again, this combination drugs are something that you may need to think about, but if you are going to combine drugs that have different mechanisms of action. That is so important. And despite some of the advantages, there's some significant limitations to the use of too many drugs. So we got to take that whole patient into consideration to make sure, again, right drug, right patient, right time. So here are some of the fixed combinations that are out there. As you know, there are many combinations with metformin. It's combined with the sulfonylurea, the glitazones, acarbose, the DPP-4 inhibitors, and the SGLT2 inhibitors. Right now, at Healing Our Village, we're using mostly the newer agents, the DPP-4s and the SGLT2s, and we're also big fans of the GLP-1s, again, because of their ability to decrease a person's appetite. As you know, obesity is one of the biggest problems that people with diabetes have, and those GLP-1s really do a significant reduction in person's appetite. So that's another reason why we use those agents. And I know they're injectable, but there are actually some oral agents that are coming very soon in that particular class. Now, when you're talking about these various combinations, it's important to look at this chart. And what you're going to see is, if you look at the bottom of each of those categories, if you just use metformin by itself, or you use sitagliptin by itself, for instance, you're not going to get as good a reduction in A1C as you'd see at the very top, where you're using sitagliptin plus metformin. And as you go down this chart, you'll see that for every single class, metformin plus saxagliptin, metformin plus linagliptin, metformin plus veldagliptin, all of these agents are better in combination than they are if you use them singly. Same thing with your pioglitazone and your DPP-4s. This chart really focuses on your various DPP-4s, and you can see that combination of these drugs work much better than either agent alone. This is a chart that looks again at the combination therapy of the DPP-4s and the SGLT2s. And again, using them singly, you get about a 0.67, 0.83% reduction. But together, you're getting 1.24, 1.08% reduction in A1C. So traditionally, we had this sort of step care approach where you start off again with the one agent, add on the next one, increase the dose. We may or may not use home glucose monitoring for all of our patients. We may or may not really focus on getting these patients to do their lifestyle changes. So I submit to you that we need to move past this traditional step care approach. And what we need to do is a pattern management approach. So all of the pharmacies and all of the pharmacists that are going to be part of the Healing Our Village network, they're all going to be monitoring patients' blood sugars. We need people to know their numbers. And so we'll be monitoring their blood sugars. We have Bluetooth enabled meters. The patient will know their numbers. They'll be able to send their numbers to you. And so we'll be able to do early aggressive treatment. And we're going to maybe start basal insulin early in the natural history of the disease. And then by home glucose monitoring, we'll be able to get those patients' A1Cs down to 6.5, 7.0. The only time you're not that aggressive, just to mention, is if you have someone who has significant cardiovascular disease disease, or if you're dealing with an elderly patient. If you have somebody in their 60s, or you have someone who has hypertension or heart failure or coronary artery disease, then you might not want to be as aggressive with your drug therapy. And if I can get someone to about 7.3 to 7.5, I'm actually very happy. So I'm not as aggressive with those patients who are elderly again, or those folks that have cardiovascular disease. So when you're looking at managing these patterns, you can see with number 2, you just need to really focus on what is that patient's issue. If their issue is fasting blood glucoses, because they're testing their sugars, so you should know if they're fasting or their morning sugars are up, then there are certain drugs that really work well on fasting blood sugar. And so metformin does well, basal insulin does well. But if that person's blood sugar is really elevated after their meals, so post-meal or postprandial blood sugars, then you need to do it with drugs that are good for postprandial hyperglycemia. So that's your DPP-4s, your GLP-1s, your pioglitazone, your SGLT2s have some effect as well. So those are the agents that you should be using for those patients. And you'll be able to get those through the formulary management system just by showing the data that proves that these agents would be the best for the patient that you're treating. When you're talking about monitoring and remote monitoring, this is an area I think pharmacists can make a huge impact on. We can actually sell the blood glucose meters out of our pharmacy, and now there are ways for a physician to bill for remote monitoring. So if you find a doctor who wants to work with you, you can have them do the billing, you can actually do the monitoring, and then you all revenue share. So this slide basically looks at the various CPT codes that are available for remote monitoring. You would basically, the doctor would get that first code where they're actually onboarding the patient. You could get the second code, which is 6415 is the billable for that, and then once a month, that doctor could receive a report card from you of all of their patients and where they're at in terms of their blood sugars, so that they could then start using their resources to help the patients that need them the most. This is the blood glucose meter that we're using in Healing Our Village. We're very excited. It's a Bluetooth meter, but it also does ketones. So a lot of you are actually maybe on a ketone diet. Everybody's on a keto diet. Everybody's trying to learn more about that. Well, one of the things that as part of a keto diet is you have to make sure that you're staying in ketosis. And so this is a way for you to monitor your ketones and or monitor your blood sugar. And all of these results go right up into the cloud. It's a Bluetooth enabled meter. Again, the patient can see it on their cell phone, and they can also send those results to you, or you can actually see it on the cloud as well. So this is what the pie charts look like. This is sort of the trend lines that come with this meter. So this is, again, something that you can have the patient look at. You can explain it to them so that they understand it. Social media, I just want to talk a little bit about that. A lot of us are using traditional ways to reach patients. You can't do that anymore. We got to get on SM. It's the way to go. So you got to figure out, you got your Facebook page, you got your Instagram, you got HOTV TV running in your waiting rooms, all right? We're about to get into video. As you can see from this presentation, we're going to start our television channel, our HIV University, and we'll be coming to you on both Facebook and Instagram very soon. So start looking for our various recipes and videos that we're going to have out there for you and for your patients. So I would love all of you to join the Healing Our Village Pharmacy Network. Go to the website, healingourvillage.com. Everything about our network is up there, and you'd be able to join the network. If you want more of these kinds of trainings, we're about to launch our first of our advanced training programs in Georgia, but we'll also be doing these programs in DC, Maryland, Los Angeles, and down in Tampa, Florida. So we're going to invite you all to watch. You can either come to the live program, or we're going to have this in modules that you'll be able to do self-study. So you'll just be able to go through the modules for this advanced training program and then take a test, and then you can be part of the Healing Our Village network. So I encourage all of you to join me in this war on diabetes. That's the way I look at it. We really have we're losing the battle battle, folks. So we have got to be able to do a better job. So join our network, be part of the solution, because we definitely have a big problem. This is our film studio here at HIV University. This is where I'm coming to you live from here. We're also taping from here. If any of you want to become one of my expert presenters, if you want to come and talk about the various conditions that you know about, give me a call. We'd love to have you on HIV TV and part of HIV University. So in terms of just, some strategies, we got to come up with some new ways to communicate with people. We're actually doing Village Talk Radio. You'll see my little emblem at the bottom. We're doing podcasting out of this studio as well. So for those who want to come on, you have patients who have a story to tell, we'd love to have them on Village Talk Radio. Come on down. We're here in Jonesboro, and we'd love to have you as part of our Village Talk radio show and podcast. So again, questions, if you have any, I'm easy to get to. You can go to healingourvillage.com. Our information is up there. Our phone numbers are there. My cell phone number is here, 703-795-1983. Our 800 number is 788-0941. Again, Dr. Lenore Coleman, President and Founder of Healing Our Village, coming to you today. These are going to be many of these programs, so stay tuned. Again, thanks for joining today, and I hope this was beneficial to you.